If the bottle says rebuilt cartilage and effortless stairs, treat that as advertising first. Glucosamine and Chondroitin are popular osteoarthritis supplements, and some people do report less pain or easier movement. The honest clinical picture is still mixed. Symptom help can appear, but cartilage rebuild language usually overshoots what controlled studies can carry for ordinary shoppers.
Okay, so when influencers talk like glucosamine sends a construction crew into your knee, should I treat that as the main promise or as the part science keeps failing to cash? And if rebuild is oversold, what outcomes should I actually watch for? Less morning stiffness, better stairs, or something on an X-ray that ordinary shoppers never see?
Watch pain, stiffness, and function. Those are the outcomes that matter day to day. These molecules relate to cartilage matrix biology, so the biochemical story is not pure fantasy. Swallowing them still does not refill cartilage like topping up oil. Osteoarthritis pain is a whole joint problem. Cartilage change, inflammation, mechanical load, muscle support, and how the nervous system amplifies signals. That is why trials disagree. A large 2025 systematic review found many positive efficacy reports and commonly paired about 1,500 milligrams of glucosamine with 1,200 of chondroitin, often against placebo or celecoxib. Other careful syntheses still call effect sizes small or clinically uncertain, especially when study quality, joint site, and preparation differ. So dose familiarity is not the same as guaranteed relief.
Who is the realistic candidate then? Someone with diagnosed knee osteoarthritis, or anyone whose knuckles feel creaky after a desk day?
Best fit is usually an adult with osteoarthritis symptoms, especially knee pain, who already treats exercise, strength, and weight context as non-negotiable. Medline Plus puts those first because they change joint load and day-to-day control. A supplement trial sits on top of that plan. It does not replace physical therapy, activity, or clinician-guided care when pain is shaping your week. There is a practical signal for pairing. In a 2025 randomized trial, a nutrition formula with glucosamine and chondroitin plus supervised exercise helped more people reach meaningful WOMAC improvement earlier than exercise with placebo. Training still helped both groups by 6 months, which means the capsule was an accelerator for some people. Not magic alone, and not a reason to skip the gym plan.
Does sulfate versus hydrochloride, or adding collagen and MSM, decide everything? Or are we arguing label chemistry while product quality is the quieter problem?
Form matters at the margins, but not enough to rescue a weak product or replace diagnosis. Combination stacks with collagen can look better in small comparative studies, and one pilot with collagen type 2 plus glucosamine and chondroitin improved several patient-reported scores, yet missed its primary endpoint. Read, that is promising, incomplete noise, not a rebuild guarantee stamped on the lid.
Before I even compare brands, is warfarin the hard stop where you call the clinician first? Or is that internet folklore around blood thinners?
Treat the warfarin conversation as real, not folklore. Also pause for shellfish-derived glucosamine if you have shellfish allergy, and loop in a clinician if you have diabetes, if you're pregnant, or if surgery is coming up. Those are screening questions, not automatic internet bans, but they are not optional small print you skip in the checkout line. If you clear those screens, run a boring experiment. Write down baseline morning stiffness minutes, stare or sit to stand pain, and one function goal. Use one consistent product for a defined window, often several weeks to a few months, while exercise stays steady. Rescore the same measures before you renew the bottle, and do not keep paying for vibes or vague joint health promises.
If a knee suddenly balloons, locks, or screams after a twist, we are not debating sulfate salts in the aisle anymore, right?
Right? Severe swelling, locking, trauma, or rapidly worsening pain is an evaluation problem first. For ordinary osteoarthritis flares, stay with proven symptom tools your clinician endorses. And remember, NSAIDs and other drugs have their own gastrointestinal and cardiovascular trade-offs that a supplement aisle does not magically erase. Popularity also misleads ranking. A 2025 network meta-analysis of dietary supplements for knee osteoarthritis did not enthrone glucosamine and chondroitin as automatic winners across every WOMAC subscale. Other studied products sometimes ranked higher for pain or stiffness in those models, which is a useful humility check before you treat the bestseller shelf like a clinical guideline.
What about high-demand joints, like active military populations? Do glucosamine and chondroitin clear a tougher performance bar there, or do they fade?
They mostly fade in that data set. The Military Systematic Review found those dietary supplements did not help the available randomized comparisons, while early physiotherapy and multidisciplinary pain programs improve pain or disability signals. Different bodies, different jobs, different evidence bar. So do not buy joint insurance for a deployment you're not living.
If the map is this uneven, why do clinics and guideline tables still mention these at all instead of shelving them permanently?
Because a subset of evidence is not empty. In the MOVES trial, chondroitin plus glucosamine looked comparable to celecoxib for pain and function after 6 months in painful knee osteoarthritis, with a generally good safety profile in that comparison. ACR-style guidance still centers exercise, weight loss when needed, and proven symptom therapies, leaving supplements as a shared decision rather than first-line doctrine for every sore joint. So the FAIR contract is narrow. A time-limited trial for some knee osteoarthritis users, scored on pain and function, stacked on exercise and medical care, with warfarin and allergy screens up front. Keep cartilage-rebuild slogans off the expectation list. If nothing meaningful moves after your planned window, the evidence-respecting move is to stop and spend the money on the basics that still work.